हेलो फ्रेंड्स, कैसे हैं आप लोग। सो टुडेज टॉपिक फॉर लॉन्ग क्लिनिक इज द अप्रोच टू न्यूरोपैथी और अप्रोच टू पेरिफेरल न्यूरोपैथी। सो जो न्यूरोपैथी है, अगर ब्रीफ में बात करें, न्यूरोपैथी इज द इन्वॉल्वमेंट ऑफ द पेरिफेरल नर्व। Basically, we have two type of nervous system: central nervous system and the peripheral nervous system. Work of peripheral nervous system is to convey the message from central nervous system to the definitive organ in the body, or to carry message from the organ or muscle to the brain. So this is the role of peripheral nervous system. In peripheral nervous system, we have anterior horn cell, we have roots, plexus, nerves. In nerves is an important part of the peripheral nervous system. For clinical point of views, for clinicians, we many patients in our OPD of neuropathy like diabetic neuropathy, leprosy, alcoholic neuropathy, HIV neuropathy, GBS. And for exam point of view, for the PG exam point of view, for clinics, for in PG exam, neuropathy may be given as a long case, in DM cases may be given as a short case, and sometimes leprosy may be kept as a small case in the exam. So approach to neuropathy is very important both for the students and for clinician. And for NEET PG, also there is a many question based on the approach of the neuropathy and causes of the neuropathy and other causes. So without delay, we will start with the how to approach a case of neuropathy. So brief about, as we discussed in various lectures about the, we have two type of lesions: upper motor neuron lesion and the lower motor neuron lesion. Upper motor neuron are the spinal cord and above spinal cord, brain stem, internal capsule, corona radiata and the cortex. In lower motor neuron, we have the anterior horn cell, we have our roots, then the plexus. After plexus we have nerves, these are the nerves, then muscle, neuromuscular junction and the muscles. So in LMN lesion may be at the anterior horn cell, nerve root, spinal nerve, plexus, peripheral nerve, neuromuscular junction and the muscle fiber. So any lesion in these areas may causes the LMN type of weakness. But today we will discuss about the neuropathy or nerve injury. Neuropathy or peripheral neuropathy is a damage of peripheral nerve and it will present as a element type of weakness. So neuropathy is a lower motor neuron type of weakness. So what feature we have? We see the atrophy of the muscles, we see the reduced tone or hypotonia, there is a weakness, decreased or absent reflexes, mute or flexor plantar. So these are feature of the lower motor neuron and these features seen in the element type of weakness in neuropathy: atrophy of the muscles, decreased tone or hypotonia, weakness, decreased or absent reflexes and the mute and the plantar response, and there is a sensory loss. So these are features of the brief features of the neuropathy. Now to start with the anatomy, because in neurology basic is always the neuroanatomy. So we will start the structure of the nerves. Nerve arises after the plexus. There is a nerve is formed. There is a various nerves in upper limb or lower limb. So in nerves, this is the nerves. This is the nerves, cross section of the nerve. So in nerve there is a multiple nerve fascicles. These are the nerve fascicles. And in each nerve fascicles there is a multiple neurons. So if we see the cut section of nerve, there is a multiple nerve fascicles in the nerve, and in each nerve fascicles there is a multiple neuron is present. In between fascicles there is a artery and the veins which supplies the nerves. So this is the cut section of the nerves. It is in depth from inside to outside. Inner side is there is a axon. Axon or nerve fiber is a single unit. Axon is a single unit of the nerve. Axon is covered by the myelin sheath in myelinated fiber and not covered in the unmyelinated fiber. Schwann cells cover the axon. So each axon, this is the each axon. In fascicles, there is a multiple axons is present. So multiple axons combine to form the fascicles. Covering of the axon is the endoneurium. Endoneurium covered the axon or each nerve fiber covered by the endoneurium. This is the connective tissue layer. Multiple axons covered by the perineurium. Perineurium forms the covering of the fascicles, and there are multiple fascicles forms the nerve, and nerve is covered by the epineurium. So outermost layer is the epineurium, which is covered the nerve. Perineurium covered the fascicles, and endoneurium covered the axon or the nerve fiber. In between the fascicles there is a neurovascular bundle, arteries and the veins which supplies the nerve and supplies the nutrition to the nerve fiber. So this is basically the cut sections of the nerve and structure of the nerve. Axon covered by the endoneurium, multiple axon forms the fascicles covered by the perineurium, multiple fascicles forms the nerve covered by the epineurium. Epineurium is the outermost layer, and there is a artery and the veins present in the nerve. Perineurium basically forms the blood nerve barrier. So endoneurium is the around each nerve fiber. It is of loose connective tissue, support nerve fiber and contain capillaries. Perineurium is around each fascicles, connective tissue layer, forms the blood nerve barrier and protect and maintain the fascicles integrity. Epineurium is around the entire nerve, dense irregular connective tissue, protect the nerve, contain blood vessels, provide strength and reduce friction. So this is all about the structure of the nerve. So nerve fiber or axon are the functional unit of the nerve. Axon are grouped formed to the fascicles. Each fascicles are surrounded by the perineurium. All fascicles are bound together by the epineurium to form a nerve. Endoneurium surround each individual fiber. Vasa nervorum supplies the nerve. This is the blood vessels. These layers provide protection, support and nourishment and allow the nerve regeneration. So this is all about the structure of the nerve. Now there is a brief about the structure of nerve fiber. There are two types of nerve fiber mainly: myelinated nerve fiber and the unmyelinated, non-myelinated nerve fiber. Myelinated nerve fiber are the inside there is a axon. This is the axon. In myelinated nerve fiber, axon is covered by the myelin sheath. This is the myelin sheath. So what is the role of myelin sheath? Myelin sheath is the lipid-rich multi-layered membrane formed by the Schwann cell. This is covered the axon in myelinated nerve fiber. The gap between the myelinated sheath is the node of Ranvier. Gap between two Schwann cells, and Schwann cells form the myelin sheath. So basically in case of myelinated fiber there is a layer around the axon. This is the myelin sheath. In unmyelinated fiber there is a no myelin sheath. Axon is covered by the Schwann cells, and in Schwann cells nucleus, multiple nuclei is present. So basically in myelinated nerve fiber there is a multiple Schwann cell is present, but in case of unmyelinated fiber single Schwann cell cover multiple nerve fiber. And there is a role of myelinated fiber is to increase the conduction velocity. Basically in unmyelinated nerve fiber there is a slow conduction, continuous conduction, but in case of myelinated fiber there is a saltatory conduction. Conduction jump from here to here, here to here and subsequently on. So there is a fast conduction seen in the myelinated type of fiber. and there is a slow conduction in the unmyelinated fiber. So myelinated fibers and the unmyelinated fibers, myelin sheath present on the around the myelinated fiber but absent in the unmyelinated fiber. Swan cell, one axon in myelinated, one swan cell covered the many axons. Node of Ranvier present in the myelinated fiber, absent in the unmyelinated fiber. A conduction is the saltatory conduction in the myelinated fiber and slow conduction or continuous conduction in the unmyelinated fiber. So this is the difference between the nerve fiber, myelinated nerve fiber and the unmyelinated non. This is also sometimes a MC question according to conduction ki saltatory conduction seen in the which type of nerve fiber or node of Ranvier seen in which type of nerve fiber, myelinated or the unmyelinated fibers. Now after this there is a nerve fiber. We discuss about the conduction. Different type of we have different types of fibers in the motor fiber, sensory fiber, autonomic. Each nerve, basically there is a nerve, maybe a pure motor nerve, pure sensory nerve, or there is a mixed nerve. Maximum nerves are usually mixed nerve which contain fiber for the motor, sensory and the autonomic. Few nerves have only sensory fibers. So maximum nerves usually are the mixed nerve. So now there is a three type of fiber in the nerves: motor fiber, sensory fiber and the autonomic fiber. So motor nerve fiber action is the from the brain signal goes to spinal cord, from spinal cord through the nerve goes to the muscles. So work of motor nerve fiber is to increase the muscle tone and there is a action of the muscle. The movement of the body or movement of the joint or movement of the muscle is the work of motor nerve fiber. From periphery, sensory fiber goes up to the spinal cord and to the brain. So sensory fiber work is to carry sensation from the peripheral part to the brain, and autonomic part is the maintain the integrity of autonomic system like sweating, like blood pressure, pulse rate. So these all are coordination of the autonomic nervous system. So in motor nerve fiber usually large. If we see size of the fiber, motor nerve fiber usually large. As we process to the sensory and the autonomic, size of the nerve fiber decreases. So motor nerve fiber is usually the larger in the size. Diameter is around 13 to 20 mm, micro m, or size decreases as we process to the autonomic. Motor fiber are usually myelinated, and these fiber are the A alpha type of fiber. So there is a various type of nerve fiber: A alpha, A beta, A delta and C fiber. So A alpha fiber usually the myelinated fiber, large one. They usually the motor fiber, control the muscle, and conduction velocities in the large fiber is usually more as compared to the sensory nerve fiber. So motor nerve fiber are myelinated, A alpha fiber, large diameter and control the muscle movement, and there is a conduction velocity is usually high. In sensory, their fiber may be myelinated, thinly myelinated or unmyelinated. Myelinated one is the A alpha or A beta. These are usually small fiber as compared to the motor fiber. They usually carry the posterior column sensation like the touch, vibration and the position sense. A delta fiber, sensory A delta fiber is usually carry the pain and the temperature, basically cold. And unmyelinated or C type fiber carry the warm sensation and the perception of the pain. So as we see, size of the fiber is large in case of motor nerve fiber and in case of posterior column sensation. So in posterior column sensation and in motor fiber are usually large fiber, myelinated fiber. So they carry impulse at higher rate, conduction is fast, because when we maintain a posture, for maintenance of the posture we require motor coordination and we require the posterior column coordination which maintain the balance. So for maintenance of the balance and posture we require the coordination of the motor and the posterior column, and these fiber require high conduction rate. That's why these fiber are myelinated, large fiber with high conduction rate. Thinly myelinated fiber are cold fiber and the pain fiber. Unmyelinated are the fiber C, warm or A. Autonomic fiber is also are the thinly myelinated or the unmyelinated, which control the our visceral pain sensation from the gut, heart rate, sweating and the blood pressure control. So this is all about the nerve fiber types: A alpha, A beta, A delta and the C type fiber. C usually autonomic and the sensory, A alpha is usually control the motor, A alpha beta control the proprioception or the joint position sense. So this is all about the conduction in the nerve fiber, how it vary from the motor fiber to sensory and the autonomic fibers. Now brief about the nerves in the body. So basically if we discuss, this is the spinal cord. So at the level of cervical cord, there are multiple roots C4, C5, C6, C7, C8, T1. They arise and forms the plexus. They forms the plexus. And plexus gives rise to multiple nerves. In अगर हम बात करें upper limbs की, तो main nerves are the axillary, musculocutaneous, radial, ulnar and median. So these are the main nerves in the upper limb: axillary, musculocutaneous, radial, ulnar and the median. Musculocutaneous supplies the anterior compartment of the arm, mainly bicep muscle. Lateral compartment deltoid supplied by the axillary nerve. Other distal arm and the hand supplied by the radial, ulnar and the median. So this is the main nerves in the area of the upper limb. Then thoracic nerve supplies our trunk. After that, the lumbosacral region, lumbosacral plexus arises, which gives the multiple nerves. LS plexus gives the nerves in the lower limb. In lower limbs, main nerves are the femoral nerve, obturator nerve, saphenous nerve and sciatica nerve. Sciatica nerve gives rise to tibial and common peroneal nerve. So these are the main nerve in the lower limb. Femoral supplies the anterior compartment of the thigh. Obturator supplies the medial and the posterior compartment of the thigh. Sciatic nerve usually present on the back side of the thigh, which supplies through the tibial nerve and the common peroneal. These are the basically basic nerve in the upper limb and the lower limb of our body. We don't go in detail of plexus, we discuss in further lectures. So brief about the dermatomes. Basically why we require knowledge of nerves and the dermatomes in case of neuropathy, because neuropathy follows the specific pattern of either of dermatomal pattern or a nerve pattern. If we see a patient of weakness in the upper limb, so if there is a distal weakness, maybe due to the involvement of the median nerve, maybe involvement of the ulnar nerve, maybe involvement of the radial nerve, or sometimes we see the dermatological pattern around the root. If there is a lesion at the root or at the level of plexus, there may be a dermatomal pattern. Like if we see neck portion is supplied by the C2, C3 and the C4 nerve. After neck, upper limb, if we discuss about the upper limb, it's C5, C6, C7. C6, C7 usually supplies the hand. T1 supplies the medial side of axilla. Then T2, T3, T4 is around at the level of nipple. If we see the landmark, then the T4 is at the level of nipple. T10 at the level of umbilicus. In lower limb, L1, L2, L3 at the level of knee. L4 supplies the posterior compartment of the thigh. L2, L3, 4 like this. S1, S2, 3 supplies the sacral region, perianal area or perisacral area. L5 and S1 in the foot. So this is the basically dermatomal ki each root that arises gives supplies to the definitive part in the body. There is some overlap between the dermatomes, but C2, C3, C4 usually supplies the nape of neck or around the neck. C5, C6, C7, C8 and T1 usually supplies the C8 up to the upper arm. After that, trunk is supplied. T4 at the level of nipples, T10 at the level of umbilicus, then L1 at the level of groin, then L2, L3 on the anterior compartment of the thigh, L3 at the level of knee, L4 on the back side of thigh, L5 and S1 on the leg and the foot. So this is the basic dermatomal level in the body. So in which important points are the T4 at the nipple level, T10 is the umbilical level, C6, C7, C8 in the hand area, neck in the C3, C2, C3 neck, groin, upper buttock L1, L3 at the level of knee, and S2, S3, S4 around the perianal area or perianal region is supplied by the L2, S2, S3, S4. So this is brief about the dermatomes. Now we comes to the definitive approach to the neuropathy. We discuss about the brief about the anatomy of the nerve, cut section of the nerve. We discuss about the proper axon or nerve fiber. We discuss the fascicles. We discuss the nerve, blood supply in the nerve, and then we discuss about the types of nerve fiber: myelinated nerve fiber, non-myelinated nerve fiber. We discuss about the types of fiber: A fiber, A alpha, A delta, A beta, A delta, C fiber, and we also discuss about the speed of the conduction in motor fibers, in sensory, posterior column fiber, other sensation fiber. So this is brief about the anatomy. We discuss brief about the nerves in the upper limb, lower limb. We discuss brief about the dermatomal levels. Now comes to the what is as we all discuss in other cases, like 3 questions in our mind: where is the lesion, what is the lesion, and why this lesion occurs. So first question is always is the where is the lesion. We discuss the nerves. So there is a lesion site, maybe the mononeuropathy, multifocal mononeuropathy, or there is a polyneuropathy. If there is an involvement of nerve, there is an involvement of a single nerve. If there is an involvement of the single nerve, this is called as mononeuropathy. If there is an involvement of more than or equal to 2 nerve in different region or different extremities, this is called as the multifocal mononeuropathy. यानी कि multiple mononeuropathy pattern या multifocal neuropathy mononeuropathy is present. Polyneuropathy is if there is a multiple nerves in same limb and different limb. If there is an involvement of the multiple nerves in same and other limbs. So this is the polyneuropathy. So there is 3 types of pattern in the where is the lesion: mononeuropathy, single nerve involvement; multifocal mononeuropathy, more than 2 nerves in different region; multiple nerves, more than 3 nerves in different regions or in same limbs. Multiple nerves. Polyneuropathy is the involvement in the peripheral nerves, and in usually polyneuropathy there is a involvement of the distal part of nerve. Usually in polyneuropathy there is a distal part involvement initially, and in lower limb or in all 4 limbs. So this is the polyneuropathy. So mononeuropathy, involvement of the single nerve may be due to we see in the median nerve injury, median nerve involvement, like in carpal tunnel syndrome, ulnar nerve, maybe compression of the ulnar nerve behind the medial condyle, medial epicondyle, radial nerve, and the common parallel. This is usually the maybe presentation of the mononeuropathy. Basically, mononeuropathy is seen in the traumatic cases or in the compressive cases. Like in case of radial neuropathy, there is a sometimes Saturday night palsy, in which there is a, if we sleep on the chair in abnormal posture of the hand, that may causes the compression of the radial nerve and may causes the mononeuropathy of the radial nerve, that may causes the wrist drop. This is a type of mononeuropathy. In median neuropathy, there is sometimes the carpal tunnel syndrome, which causes the involvement of the median nerve only. This may be a mononeuropathy. In sometimes in lower limb, due to the stretching of the nerve, there is a compression of the common parallel, may causes the foot drop. As we see one cases in my YouTube channel, that one patient come to us with he work for prolonged hours in the गेहूं के खेत पे उसने काफी देर तक कटाई करी थी, उसके बाद में उसको बायलेटरल फुट ड्रॉप हो गया था। तो दैट इज आल्सो टाइप ऑफ कंप्रेसिव न्यूरोपैथी और ए कंप्रेसिव न्यूरोपैथी दैट इज टेम्परेरी एंड दैट इज basically improve over a days to the months. So basically mononeuropathy is the mononeuropathy is the median, ulnar, radial and common parallel. So these usually neuropathy is due to the compression or the traumatic cause. Then the multifocal mononeuropathy, there is an involvement of the like one nerve in this hand, one nerve in this limb. So this is a presentation of the type in the multifocal mononeuropathy. Most important example in the multifocal mononeuropathy is the leprosy. Leprosy is a classical presentation of this type of presentation, like involvement of the ulnar in the one hand or ulnar in the both hand, or there is a involvement of the common parallel in the one limb or ulnar involvement in the one limb. So this is a classical example of the leprosy, is a classical example of the multifocal mononeuropathy. Diabetes mellitus may sometimes present like this type presentation, but most common is the leprosy. Sometimes when the evolving polyneuropathy is there, that may present as a multifocal mononeuropathy type of presentation. Now polyneuropathy. Polyneuropathy is the involvement of the multiple nerves in limbs, different limbs or all limbs. This is usually follow the length dependent pattern. Length dependent pattern means कि longest nerve affected first. Like longest nerve in our body is the lower limb in peripheral nerves. So first involvement of the length dependent type and the lower limb. So first there is an involvement of the foot, then in both foot, then neuropathy progress to the knee. After knee, when neuropathy symptoms reaches up to the knee, then there is a start of the symptoms in the upper limb. As after the knee there is a longest fiber in the upper limb. Symptoms start in the upper limb, then they progress to the elbow in the both limb, then there is a maybe progression of the symptoms in the lower limb up to the thigh. So polyneuropathy shows the length dependent phenomena, or started from the distal, then proximal to the knee. After knee there is a start symptom in the hands, progress to the elbow, then maybe involved to the thigh regions. So length dependent pattern, and this is also called as a gloves and stockings type of neuropathy. This is a classical presentation of the polyneuropathy of any cause. So gloves and stocking type of neuropathy, ठीक है, gloves and stocking type of neuropathy. Usually polyneuropathy present as a gloves and stocking type of neuropathy. Length dependent phenomena is there, but sometimes there is a involvement of the proximal nerves also, as we discuss further. Now second question. So first question is the where is the lesion? Lesion at the single nerve level, at the multiple nerves in the other multiple limbs, or there is a polyneuropathy. Then second question in our mind is the what is the lesion? So in what is the lesion, there is a two type of question is the axonal or the demyelinating. There is a involvement of the axonal type of damage, or there is a demyelinating type of damage, or a small fiber neuropathy or a large fiber neuropathy. So now we discuss about the axonal and the demyelinating type. So usually this is our axon. This is cell body. So in case of myelinated nerve fiber, axon is covered by the myelin sheath. This is the node of Ranvier. So in case of demyelination, what is happened? In case of demyelination, this is the myelin sheath. What is the role of myelin sheath? We will discuss. There is a role of myelin sheath is to conduction fast through the node of Ranvier. So role of myelin sheath is to provide the fast conduction in motor fiber and in fiber of the posterior column sensation like joint position, vibration sensation, and proprioception. So basically role of myelin sheath to give the fast conduction. Axon, this is the axon. This is usually gives the continuous or slow conduction. So in axonal type of neuropathy, there is a damage in the axon. Damage in the axon. There is a damage in the axon. So if there is a damage in the axon, what it will cause? It causes there is a no nutrition goes to the distal part, distal nerve or the muscle. So in case of axonal, there is a disruption in the conduction through the axon. It will causes the early atrophy. Atrophy is more. Involvement of the sensory fiber is more because motor fiber is usually myelinated fibers. So in case of sensory, involvement is more as compared to motor. Early atrophy due to the loss of nutrition. Sensory involvement is more than motor nutrition. And usually there is a distal involvement first. Because when there is an axon damage, there is a no nutritional supply to the distal part. So symptoms started from the distal and then proximally progress to the proximal part. So in case of axonal type of damage, there is a early atrophy, sensory involvement more than motor, distal involvement initially, then progress to the proximal. In case of demyelinating neuropathy, what happened? In case of demyelinating, the myelin sheath is damaged. So what it will cause? It causes the slow conduction. Axon is intact in case of demyelinating lesion. So it will causes the decreased conduction. Decreased conduction, and it will causes involvement of the motor fiber more as compared to sensory. Sensory is also involved, but involvement of the motor fiber is more. So weakness is more in case of demyelinating neuropathy. Early weakness or weakness is more, and there is a poor conduction or slow conduction. So that will causes the loss of reflexes early. Reflexes lost seen in the early in the demyelinating neuropathy, and there is a proximal and distal both weakness seen simultaneously. Like in Guillain-Barré syndrome or CIDP, there is a weakness of the both proximal and the distal part. Reflexes lost, areflexia, weakness is more, motor symptom is more, motor sign is more as compared to sensory symptoms. But sensory symptoms are also there, and there is a slow conduction seen in the demyelinating neuropathy. So this is brief about the what is the lesion. Lesion is demyelinating type or lesion is axonal type. Usually demyelinating neuropathy sometimes have better prognosis, better recovery. Axonal in case of demyelinating neuropathy, there is a recovery is usually fast. In axonal there is a slow recovery. In basically axonal neuropathy is also called as a dying back neuropathy. Dying back neuropathy. Dying back neuropathy. Basically क्योंकि damage starts from the distal and then progress to the proximal area, dying back neuropathy. So this is brief about the how we discuss about the axonal type of neuropathy and the demyelinating type. अब small fiber neuropathy is basically small fibers or the fibers of the pain, temperature fiber are usually the small fiber, autonomic fiber. Large fiber are the fiber of the motor and the joint position, vibration and proprioception. So in case of small fiber neuropathy, there is a more symptoms like tingling sensation, paresthesias, numbness, pain. So painful neuropathy is usually the small fiber neuropathy. These have the more symptoms of the pain, and the abnormal sensation, paresthesia, and there is a much more autonomic symptoms seen in the small fiber neuropathy. In case of large fiber neuropathy, there is a motor weakness and there is a loss of reflex. So now third question in our mind always is the why this lesion occur. So why this, we have the mnemonic like the vitamins. So in this we discuss what are the common causes of the neuropathy. So vasculitis is maybe a cause of the neuropathy, or vascular causes like ischemic neuropathy. Sometimes in case of basically peripheral vascular disease, VCD, ischemic neuropathy like tingling sensation, paresthesia, pain associated with the peripheral vascular disease. So vasculitis. Then the infective causes. In infective causes, there is a most common cause is the leprosy in India, is a common cause of infective cause of the neuropathy. HIV, this is also a common cause of the neuropathy. Then the traumatic causes. In traumatic causes, I also discussed the mononeuropathy is common with the trauma like radial, ulnar, medial, depend on the site of the trauma fracture. Sometimes in humerus fracture there is involvement of radial nerve may be there. So in traumatic neuropathy. Then the autoimmune causes. In autoimmune causes, there is a Guillain-Barré syndrome, GBS or CIDP, which is a common cause of the demyelinating neuropathy. Then metabolic and the nutritional. In metabolic, there may be the in the hepatic failure, renal failure, maybe there is a neuropathy. In nutritional, vitamin B12 deficiency, vitamin B6 deficiency, folate deficiency. These all may be the cause of the neuropathy. Then iatrogenic. In iatrogenic, there is a drug-induced causes. In drug-induced causes, maybe the isoniazid, which is given in the anti-tubercular treatment, and sometimes the multi-drug resistant tuberculosis treatment also gives rise to the peripheral neuropathies. Other than this, cancer chemotherapy drug like cisplatin and other chemotherapy drugs may causes the iatrogenic neuropathy in the cancer patients. Then syndromic. In syndromic, there is a Charcot-Marie Tooth disease, CMT. Charcot-Marie Tooth disease is a hereditary type of neuropathy, and this is usually demyelinating type of neuropathy. So this is all about the causes of the brief about the causes of the neuropathy. In metabolic, there is a diabetes. I forget, it is a most common cause of peripheral neuropathy. So diabetes, hypothyroid, hypothyroid, renal, hepatic failure, nutritional, B12, B6 deficiency, folate deficiencies, and in case of T4 toxin induced also like the lead, which causes the pure motor type of neuropathy. Arsenic is sometimes present in some medication, Ayurvedic medication, homeopathic medication, may be a cause of the toxin induced neuropathy. So this is all about the where is the lesion, what is the lesion, and why this lesion occur, brief about the neuropathy. Now we will discuss how to go for the history and the examination in case of neuropathy. So for history point of view, I taken a 7 question list in which we proceed for the history point. So what system is involved? First question is the what system is involved in taking the history. Like if there is a motor, then the symptoms are the weakness of the limb, or weakness of special group of muscles, that may be the weakness of the thumb, weakness of the little finger, depend on the nerve. Motor symptoms other than the is the atrophy, grip weakness, कि there is a slippage of slipper may be there. So for motor weakness, we should ask for the weakening of the grip, weakness in the limb. There is a slippage of something from the hand, slippage of the slipper from the foot. There is a weakness of the finger, lifting of the foot, and there is a atrophy of the muscles. So these are the motor symptoms of the neuropathy. For sensory, we may have the tingling sensation, paresthesias, numbness, pinprick sensation, burning sensation. So tingling sensation, paresthesia, pinprick sensation, needle-like sensation, numbness, burning sensation, severe pain, these all are symptoms of the sensory type of neuropathy. If sensory symptom is predominant, then we think about the sensory common predominant sensory neuropathies. If motor symptom is predominant, then we think about the motor neuropathies. Autonomic symptoms are increased sweating, decreased sweating, increased heart rate, decreased heart rate, diarrhea, decreased gastric emptying, decreased gastric emptying, gastric paralysis, constipation. So these are, इसके अलावा urinary problem, erection problem, these are the symptoms of the autonomic type of neuropathy. So what system is involved? Either pure motor, pure sensory, or mixed type of all, combination of motor sensory, combination of motor sensory, autonomic. So this is all about the symptoms of the motor and the sensory neuropathy. Now second question is our mind, the what is the distribution of the weakness? यानी कि distribution of the weakness is only distal, distal plus proximal, focal or asymmetric or the symmetric. Like usually most common presentation of the peripheral polyneuropathy is the distal type of weakness. As I say, it follows the latch dependent pattern. Initially there is an involvement of the foot, then progress to the knee. After knee there is an involvement of the hand, and then progress to the elbow. So this is the basically gloves and stockings type of pattern that is classically seen in the polyneuropathy, that is distal type of pattern with symmetric type, distal and symmetric type of pattern seen in the polyneuropathy. In case of mononeuropathy, as in the median nerve involvement, mononeuropathy, there is a focal involvement and there is a asymmetric type of weakness, involvement of the only one hand. Either there is a, if there is involvement of the ulnar nerve, there is a weakness of the ulnar area and there is a sensory loss in the same area. So there is a focal and the asymmetric involvement seen in the motor neuropathy, and distal and the symmetric involvement seen in the polyneuropathy. Classically distal and plus proximal both involvement seen in the CIDP and the GBS, which is a type of demyelinating neuropathy. This present usually proximal and the distal both type of. So what is the distribution of weakness? If there is a only distal weakness, asymmetric weakness, we think about the mononeuropathy or mononeuropathy multiplex. If there is a symmetric involvement and there is a distal involvement, we think about the polyneuropathy. If there is a proximal or distal both involvement, there is a, we think about the GBS or the CIDP, depend on the history of the onset. Then third is the what is the nature of sensory loss. If there is a sensory loss, what is type of sensory? There is a temperature and pain involvement is more, paresthesia is more, then the small fiber neuropathy chances is high. If there is a loss of vibration, proprioception, and there is a areflexia, loss of reflexes and weakness, then there is an involvement of the large fibers. So there is a which type of sensory loss is there, then we approach accordingly. Now, is there is a evidence of UMSN? Why we are asking for the UMSN? For the myeloneuropathy. There is a few causes of the myeloneuropathy in which there is a neuropathy with UMSN. Like in case of vitamin B12 deficiency, subacute combined gingivitis SCCD. There is a neuropathy with plantar extensor and knee reflex may be brisk. So this type of presentation may be seen in vitamin B12 deficiencies, hepatic myeloneuropathy, hepatic failure. In case of hepatic failure, there may be sometimes hepatic myeloneuropathy. इसके अलावा in case of copper deficiency, there may be the presentation like myeloneuropathy. So this is the, if there is a UMS sign, and in case of spinocerebellar ataxia, in some cases there is a neuropathy with UMS sign. So neuropathy, but like presentation with UMS sign, these are maybe because if there is a fasciculation, we should, and UMN plus LMN sign both with fasciculation, then we think about the anterior hornstead disease or the motor neuron disease like presentation. So this is the, if there is a UMS sign, what may be the approach. What is the temporal evolution? What is the duration of the history? Like acute presentation, like less than, if there is a history of the less than 4 weeks, this is the acute neuropathy. Common causes are the Guillain-Barré syndrome. If there is a subacute type of history, 4 to 8 weeks, and in chronic there is a more than 8 weeks. So acute presentation, subacute, chronic. Acute usually the GBS. Chronic, in chronic there is a maybe CIDP, and other like diabetic neuropathy or vitamin B12 usually present as a chronic type of presentation. Then the monophasic illness, progressive illness or the relapsing limiting illness, like GBS is a monophasic illness. Other neuropathies like diabetic neuropathy, the progressive type of neuropathy. CIDP is usually the relapsing limiting type of neuropathy. So what type of temporal evolution is present? Next is there is evidence of hereditary neuropathy. For hereditary, there is a positive history of the neuropathy present in the family. Lack of sensory symptom despite the sensory sign. In case of hereditary neuropathy, there is a sensory sign is present, but there is a no history of the sensory symptoms, and there is a presence of skeletal deformity like high arch foot, scoliosis, and hamarto. These are the feature of the hereditary type of neuropathy in which there is a CMT. Charcot-Marie 2 disease. These are various types, demyelinating type, axonal type, and different type of presentation is there. So hereditary neuropathy, there is a history of family history. Sensory symptoms is not present, but there is a sensory sign. Skeletal deformity like high arch foot, scoliosis or hamarto is present. This suggests the hereditary type of neuropathy. Then the next question, last question is that there is any history of the medical condition to find out the etiology of the neuropathy. Like history of cancer, then we should think for the drug-induced causes or some cancer-related neuropathies. Diabetes mellitus for the diabetic neuropathy. Diabetic neuropathy may present like a mononeuropathy multiplex, polyneuropathy, plexopathy, as a case of amyotrophy, or so diabetic neuropathy may present as a various type of presentation with autonomic involvement, with sensory motor, with autonomic. Hypothyroid, there is a history of hypothyroid may causes the neuropathy. Autoimmune disease की history may causes the vasculitis. Drug or toxin exposure, for the drug induced or the toxin exposure like arsenic. If there is a person working in the lead industry or the battery industry, there is a maybe chances of the lead induced neuropathy. If patient is taking ayurvedic medicine or homeopathic from long duration, there is chance of arsenic toxicity. Some toxin like the glue sniffing may causes the neuropathy. So some toxin induced, drug induced, or other the alcohol. If there is a history of alcohol, chronic alcoholic is there, then the chances of alcoholic neuropathy is also high. Alcoholic neuropathy is also a common cause of neuropathy in Indian scenario, where there is a chronic alcoholic condition. Now, with these 7 points, we discuss how we take proper history, like which system is involved, motor, sensory, autonomic, or the mixed. Which type of fiber is more in neuropathy, axonal type है, demyelinating type है, small fiber, large fiber, किस तरह के fiber और sensory loss किस तरह का है, फिर आपको कोई मेडिकल इलनेस की हिस्ट्री तो नहीं है, कोई हेरिडिटरी प्रॉब्लम की हिस्ट्री तो नहीं है, ड्यूरेशन ऑफ इलनेस क्या है, लेस देन 4 वीक्स, 4 to 8 वीक्स की, more than 8 weeks. So this is the how we approach a case of neuropathy journey. Now the examination, what points in the examination important is the examination of the motor system. We see for the wasting, we see for the weakness like proximal weakness or the distal weakness, the grading like in GPS and the CIDP, proximal and distal, both type of weakness is present. In case of other peripheral neuropathy, there is a mainly the distal weakness, then the tone is usually reduced or absent, hypotonia is there, DTR is usually reduced, but in case of myeloneuropathy, there is maybe the knee reflex brisk, plantar reflex, usually extensors we should examine for the extensor for the myeloneuropathy. Sensory examination should be important in detail, pain, temperature, touch, vibration, joint position sense. So detailed sensory examination is important for the neuropathy examination. Examination of the skeletal system like hematose, scoliosis or any deformity. Then the skin changes, like skin changes may be seen in the various type of neuropathy like leprosy, and some cases of the hypothyroid type of neuropathy, diabetic neuropathy, skin changes, nail changes are also a present of the neuropathy. Nerve thickness and the tenderness. Nerve thickness and the tenderness, usually we look for the ulnar nerve thickness, we look for the common peroneal nerve thickness for the approach to the leprosy cases in which there is a nerve thickness or maybe the tenderness at the nerve. So this is the brief about the examination in case of the neuropathy. Now investigation. Most common investigation are the blood sugar, because diabetic neuropathy is a common cause of neuropathy. Then the routine profile CBC, KFT help to rule out the any hepatic function, liver function or any anemia or other causes. Thyroid profile, HIV, vitamin B12. Vitamin B12 is a common cause of neuropathy in India. Then the most important investigation for the neuropathy is the nerve conduction studies. So we go for the nerve conduction studies of the upper limb, lower limb, forelimbs. And we basically differentiate between the there is a weakness involvement of the mononeuropathy multiplex or polyneuropathy. If there is a polyneuropathy, this damage is either due to the axonal or the demyelination. So this all be clear by the nerve conduction studies. Other specific tests we require in some cases like a serum protein leptophoresis if we suspecting the neuropathy in case of multiple myeloma. Vasculitic profile we suspecting the vasculitis. ANA profile for the same for vasculitis or the autoimmune causes. In case of specific causes, GBS may go for the antibody testing. So these are the specific tests, and basic test is the routine profile, and nerve conduction study is the main investigation of the choice. Now in nerve conduction studies we do the lower limb nerves like common peroneal nerve, tibial nerve and the sural nerve in sensory. Superficial peroneal and saphenous may be done. In upper limb, median, ulnar, motor sensory, radial, motor sensory, we go for the axillary, musculocutaneous, supraspinatus, suprascapular nerve. So how to differentiate between the axonal and the demyelinating neuropathy on the basis of NCP. So basically axonal neuropathy, as we say, the length, it shows the length dependent pattern, involvement of the distal is more than the proximal. In demyelinating neuropathy, there is a diffuse proximal plus distal involvement. System involved, more sensory than the motor. In case of demyelinating, more predominant the motor weakness. If we differentiate between the nerve conductions, first is the amplitude. In case of axonal, because there is a integrity of axon is disturbed, there is a reduced in the amplitude. But in case of demyelinating neuropathy, amplitude is normal. So this is also a MCQ question in various exam. कि nerve conduction studies differentiate between the axonal and the demyelinating. So first point is the amplitude. In case of axonal, there is a reduced amplitude. In case of demyelinating, there is a amplitude is normal. Second point is the conduction velocity. Conduction velocity is normal in the axonal, and there is a reduced conduction velocity or conduction block seen in the demyelinating type of neuropathy. Distal latency is normal in the axonal type of neuropathy, and there is a prolonged latency seen in the demyelinating neuropathy. So for axonal neuropathy, there is a reduced amplitude, but there is a normal latency and normal conduction velocity. And conduction velocity is normal, distal latency is normal, but there is a amplitude is reduced. In case of demyelinating neuropathy, there is a prolonged distal latency, reduced conduction velocity or conduction block, or there is a amplitude is usually normal. This is the basic differentiate in the axonal and the demyelinating neuropathy on the basis of NCB. One more point, conduction block usually asked sometimes in NEET exam. basically the conduction block seen in the which type of neuropathy, axonal or the demyelinating. So conduction block is a feature of the demyelinating type of neuropathy. Now one more slide about the axonal and the demyelinating neuropathy. This is also for the MCQ type. Like axonal neuropathy is called as the axonopathy. Axon, normal axon, intact myelin and the axons. If there is a damage in the axon, there is a axonic damage, axonal degeneration or loss of axon. In nerve conduction, we discuss the reduced amplitude, conduction velocity normal or mildly reduced, distal latency is normal. So in case of axonal neuropathy, there is a primary damage of the axon. There is a Wallerian degeneration occur distal to the site of injury. Myelin may be secondary affected. So in case of axonal injury, initially axon is affected and secondary myelin may be affected. Clinical features are the slowly progressive, length dependent phenomena as I discussed, more sensory involvement than the motor in case of axonal neuropathy. Early sensory symptoms like numbness, paresthesia, pain, weakness are usually late. So in case of axonal neuropathy, there is an initial sensory symptom, numbness, paresthesia, pain, weakness usually late. Sensory symptoms predominant as compared to motor, slowly progressive, length dependent type of phenomena, gloves stocking type of phenomena. Classical example are the diabetic peripheral neuropathy, alcoholic neuropathy, toxin induced neuropathy like chemotherapy or the uremic neuropathy, all are the example of the axonal type of neuropathies. So common causes diabetes, alcohol, toxin, uremia and the genetic causes. Now the demyelinating neuropathy, there is a damage in the myelin sheath. This is the normal myelin, this is the demyelinating fiber, myelin loss, axon usually intact. Pathophysiology, primary damage to the myelin sheath, conduction is impaired due to the loss of insulation, axon is usually intact, so no Wallerian degeneration. NCB में there is a reduced conduction velocity, prolonged distal latency, there is a maybe conduction block, temporal dispersion and amplitude is usually normal or mildly reduced. Clinical features usually subacute to acute like in GBS or the CIDP, more motor involvement like in weakness and the areflexia are the feature of axonal type of neuropathy, may be symmetric or the asymmetrical, usually symmetrical in the case of GBS or sensory symptoms may be mild, Kinelus involvement may be occur in the case of demyelinating neuropathy like GBS. Common causes are the autoimmune like GBS and the CIDP, paraproteinemia like multiple myeloma, infection like CMV, HIV and the genetic disease like CMT which may be axonal or the demyelinating. GBS, CIDP, multifocal motor neuropathy with conduction block, also a type of demyelinating neuropathy with multifocal neuropathy type of presentation. Hereditary demyelinating neuropathies. Prognosis offer better than the axonal neuropathy. Recovery is good if treated early because of the demyelination can occur. So this is about the differentiate between the axonal type of neuropathy and the demyelinating type of neuropathy. So now after we go for the history, detailed history in the detail like history for the where is the lesion, what is the lesion and why this lesion occur, all 3 points. Then proper examination of the nervous system, especially the sensory nervous system like pain, touch, temperature, vibration, joint position. Sensory nervous system examination is very important. With motor system examination looking for the atrophy, deep tendon reflexes, superficial reflexes, plantar reflexes. Then we reach the anatomical diagnosis. Like anatomical diagnosis, there is a neuropathy. So where is the lesion? Mononeuropathy like presentation, multiple mononeuropathy like leprosy and the polyneuropathy. Then what is the lesion? Axonal type of neuropathy or the demyelinating neuropathy, small fiber or the large fiber. Few points we will differentiate from the history point of view, and then the nerve conduction history is important to differentiate between the axonal and the demyelinating. Then why this lesion occur? Like vitamins, vasculitis, leprosy, traumatic, GBS, CIDP, vitamin B12, hypothyroid, alcohol induced, chemotherapy induced, heredity. These all are the causes of the peripheral neuropathy. Now what is the treatment? Treatment basically depend on the cause. If there is a diabetic, then we should control for the diabetes, and there is also symptomatic management with physiotherapy, exercises. If there is a vitamin B12 deficiency, we correct vitamin B12. If there is a alcoholic neuropathy, we stop the alcohol intake and treatment of the cause. Nutritional supplement like thiamine deficiency sometimes may causes the neuropathic symptom in the alcoholic patient. So treatment basically depends on the cause. If there is a usually treatment is usually conservative in maximum cases, but maybe surgical if there is a compression somewhere may causes the neuropathy like radial neuropathy or any other neuropathy after trauma, that may require the surgical treatment. Physiotherapy and rehab is an important part of the management of the neuropathy. This is all about the neuropathy. One more point, there is a 3 point, like if there is a nerve injury, there is a 3 types of nerve injury: neuropraxia, axonomatosis, and neuromatosis. Basically, neuropraxia is a mild form of nerve injury. Axonomatosis is more severe than the neuropraxia, and neuromatosis is the more severe injury. These are the 3 types of injury, nerve injury. Neuropraxia is basically mild type of nerve injury, maybe due to the stretching of the limb, or there is a mild compression due to the abnormal posture, like in case of the Saturday night palsy. So that is a type of neuropraxia type of neuropathy. This is usually recover by itself, no usually treatment required. Sometimes mild treatment, symptomatic treatment is required. Axonomatosis, there is a damage in the axon or compression of the axon, that may be due to the trauma, but in there is a axonomatosis, there is a injury in the axon, but there is a no complete transaction of the nerve, so recovery is present, and there is a less severe as compared to neuromatosis. In neuromatosis, there is a complete injury of the nerve, maybe complete transaction or maybe a partial transaction. In these cases, it may require the surgical approach for the treatment. So this is a 3 types of nerve injury: neuropraxia, axonomatosis, neuromatosis. Neuropraxia is a mild form of injury, self-recovery, mild compressive features may be there, mild compressive demyelinating neuropathy feature. Axonomatosis, there is a damage in the axon, but nerve is integrity. In case of neuropathy, there is a maybe a transaction of the nerve. So this is the all about the neuropathy. So this is all about the how to approach a case of neuropathy. We discussed the anatomy, we discussed the nerve fiber, dermatomes, nerves. We discussed how to approach in a clear way, what are the causes, how we treat. So this is all about the neuropathy. If you have any question regarding the approach to neuropathy, you may comment us. Please like, share our video, comment करिए और हमारे चैनल को सब्सक्राइब करिए. थैंक यू.